Hello, my name is Hannah Hernandez, and today I'll be presenting my evaluation proposal for the Continuity of Care Program, or COC, at the Andrews Center in East Texas. This evaluation focuses on how well the COC program supports individuals with serious mental illness during a particularly vulnerable time, the transition from inpatient psychiatric care back into outpatient care in the community. As someone working closely with rural mental health systems, I've seen firsthand how clients will often fall through the cracks during this transition. My goal with this evaluation is to provide actionable insights into whether the COC program is helping reduce hospitalizations and keep people connected to the care that they need. Let's start with the broader issue this program is designed to address. We know from research that individuals living with serious mental illnesses are at significantly higher risk of relapse, suicide, and psychiatric rehospitalization after they leave an inpatient facility. This risk spikes when there's a delay in follow-up care. Unfortunately, in rural areas like East Texas, delays are extremely common due to limited transportation, unstable housing, and a shortage of mental health providers and fragmented care systems. The COC program at the Andrews Center was created to address these specific gaps. Andrews Center is the local mental health authority for 5 counties: Smith, Henderson, Van Zant, Wood, and Rains. The COC program helps people discharged from state hospitals or psychiatric units transition smoothly into outpatient services. COC coordinators schedule follow-up appointments within 7 days of discharge, complete assessments of non-clinical needs like housing, benefits, or transportation, and coordinates with outpatient providers, jail liaisons, and other LMHAs, to name a few. The overall goal is to make sure clients don't fall through the cracks and to reduce the risk of readmission. This kind of program is especially vital in East Texas, where vulnerable clients often lack access to the supports needed for long-term stability. The purpose of this evaluation is to find out whether the COC program is actually achieving its intended outcomes. Are clients engaging in outpatient services after discharge? Are hospitalization rates going down because of this structured follow-up? These are questions that matter to program leaders, hospital partners, policymakers, and most importantly, to the clients themselves. To guide this evaluation, I developed 4 key research questions. First, does timely follow-up, specifically scheduling an outpatient appointment within 7 days, reduce the likelihood of psychiatric rehospitalization within 90 days? Second, do non-clinical supports like addressing housing or transportation issues help clients stay connected to services during the first 2 months after discharge? Third, how do clients perceive the transition process, such as did they feel supported, informed, and included in planning their next steps? And finally, does having contact with a COC coordinator before discharge increase the likelihood that clients actually attend their first follow-up appointment? These questions not only look at whether the program works, but how and why it works, or where it might be falling short. The type of evaluation I'm using is an outcome evaluation. I'm not just looking at what the program does in theory, I'm looking at the actual changes in client outcomes, such as, are clients staying out of the hospital? Are they following through with outpatient care? Are barriers like housing or transportation being addressed in meaningful ways? Outcome evaluations are particularly useful when a program has already been implemented and needs evidence about its effectiveness. It's a way to show whether the program is worth continuing, improving, or expanding. This approach also allows me to connect outcomes like lower rehospitalization rates with specific processes like the 7-day scheduling goal or the use of non-clinical assessments. In that way, it also helps us understand what elements of the program are driving success. To answer these questions, I'm proposing to use a mixed methods design, which combines both quantitative and qualitative data. This approach offers a more comprehensive understanding of both what's happening and why it's happening. Here's how the evaluation will work. First, I'll use electronic health record data from Andrews Center's EHR system called SmartCare to track things like when follow-up appointments were scheduled, whether they were attended, what services were provided, and whether non-clinical needs were documented. Second, I'll analyze client satisfaction surveys from a subset of about 50 clients. These surveys will explore how clients felt about their discharge planning, whether they felt supported, and what barriers they faced. Third, I'll collect staff feedback through surveys or focus groups. This will provide insight into system challenges like workflow issues or communication gaps between hospitals and community services. Fourth, I'll be using internal program logs and audit tools to track whether the COC team is meeting documentation timelines, completing assessments, and following up appropriately. Lastly, I'll be reviewing hospital discharge records to verify discharge dates and identify trends in referral patterns. This sample will include all clients referred to the COC program over a 6-month period who have complete data. Using these multiple sources helps ensure that I'm seeing the full picture and not just one piece of it. So why does this evaluation matter? First, it gives Andrews Center leadership evidence about what's working and where improvements are needed. For example, if we see that timely aftercare significantly reduces rehospitalizations, that's a strong case for investing more resources into scheduling workflows and possibly hiring more staff. If we find that housing and transportation barriers are keeping people from staying in care, then this evaluation could support deeper partnerships with housing organizations or local transportation programs. If clients report feeling confused or unsupported during the transition process, that may highlight a need for stronger staff training and client-centered communication. And if certain counties are showing worse outcomes, perhaps due to a more severe provider shortages, this data could be used to push for regional policy changes like expanding telehealth options or funding mobile clinics. In short, this evaluation provides actionable insights that can guide both practice and policy and support a more effective and equitable mental health system. In conclusion, this evaluation is about more than measuring success. It's about using data to support real change. The COC program plays a vital role in ensuring that vulnerable clients stay connected to care when they leave a psychiatric facility. And by focusing on outcomes like timely follow-up, service engagement, and client experience, this evaluation will help the Andrews Center and its partners make data-informed decisions about how to improve transitions of care. Thank you so much for your attention, and I look forward to hearing all of your presentations as well.